This is Cristian Gragnaniello narrating on behalf of all authors for the chapter on peripheral nerve stimulation for management of neuropathic pain. This is a field that has met many advancements over the last decade, and this slide shows an overview of what we'll be discussing in the next few slides. Starting from the theory and why this is important. So it's known that peripheral nerve stimulation, which is the targeted passage of an electrical current through the fibers of a localized nerve, can help in the treatment of neuropathic pain. This is based on the gate control theory of pain, where a persistent simultaneous activation of the specific large A delta nerve fibers has shown to be able to overcome and suppress the transmission from the associated small nociceptive C fibers at the level of the spinal cord, and result in a decreased nociceptive signal that's then relayed to the sensory cortex of the brain. This finds many applications nowadays, and it's especially important in trigeminal neuralgia, postherpetic neuralgia, conditions such as migraine, but also occipital neuralgia, chronic back pain and failed back pain syndrome, sacroiliac pain, fibromyalgia, post-surgical pain, post-amputational pain, and CRPS. Patient selection is the most important step for a successful procedure. Patient needs to demonstrate not to have any other psychological confounders. There must be an EMG confirmed neuropathic pain that is refractory to other conservative measures, so there must be an extensive and exhaustive trial of conservative measures. Also, pain should localize to a particular nerve root distribution and not be widespread. And there must be at least a 50% reduction of pain severity that is achieved in response to the preliminary temporary testing. For what concerns the technique, and we'll show a few diagrams about these, the electrodes can be placed in an open fashion or percutaneously. For what concerns the open procedure, the nerve is exposed and the electrodes are placed next to the nerve, surrounded by fascia. The leads for the first part of the procedure are usually kept in for a couple of days, and the patient is asked to fill up a chart of pain scores that are recorded at different stimulation intensities, and is really useful to guide for the permanent placement. For what concerns the percutaneous placement, a TWOI needle is inserted under X-ray guidance perpendicularly to the nerve from medial to lateral or vice versa, and the electrode is guided and positioned over the region of maximal pain along this nerve root. This is a drawing showing the possibilities of placement of this peripheral nerve stimulator for ulnar nerve stimulation. We can see here drawn out the C8 nerve distribution, but also the ulnar nerve as it progresses from the forearm through the wrist into the medial aspect of the hand. In this specific procedure, it is very important to recognize the surgical anatomy, as this region, especially at the elbow, can be quite difficult to understand, and certainly it can lead to failure of the implant. Starting from the top left image, this is a drawn out of the skin incision. the underlying muscle and ligamentous fibers are shown. Essentially, the aim here is to essentially slide under the ulnar nerve that's been mobilized, just as one would do ulnar nerve decompression at the elbow. And it's very important to actually anchor these leads really well to the fascia, because in this very highly mobile region, it's very easy for these to get displaced. This is a quick slide, and I apologize for this to be this busy. There have been several reports on the use of peripheral nerve stimulation techniques to treat different types of peripheral pain. Mataro and his colleagues reported on chronic migraine, reporting more than 50% rate of headache resolution with only periodic breakthrough headaches. Professor Slavin at UIC Chicago has demonstrated 70%, over 70% rate of more than 50% improvement in pain for cases of craniofacial pain. Dr. Johnson demonstrated 50% reduction in pain severity in a small series of patients treated for trigeminal neuralgia, postherpetic neuralgia, or facial trauma. Hassenbusch also used this for reflex sympathetic dystrophy, very debilitating disease, showing over 60% pain reduction following the implantation of the electrodes. Verils also used these for multifocal chronic pain, having a reduction of 4, on average of 4 on the pain scale points on an 11-point scale. And Gilmore treated post-amputation neuropathic pain with showing more than 50% relief at 4 weeks in the treatment of arm pain, in the treatment arm of his study. This is my final slide. Just to say that PNS, peripheral nerve stimulation, is a field that has been continuously evolving. Just a couple of pointers here and take home messages to say that the widespread adoption of ultrasound to guide the lead placement has enabled practitioners essentially to also target deeper areas, deeper nerves, which historically had to be done open, so minimizing soft tissue damage, incisional pain, and avoiding all the possible complication of an open procedure. Right now, there are available already on the market external pulse generators that are rechargeable, and essentially they're worn outside the body and communicate directly with the electrode leads, and these essentially mitigate some of the nuisance of having to exchange batteries, in the risk for malposition, and essentially streamlining this process, facilitating a single stage implantation, after which the device can stay there indefinitely. Also, new sleek low-profile external generators that can be worn on a single layer of clothing have been developed, and this is very important for patients so that they don't feel as they need to show their disease and their issues to the world, improving also the psychological effect of having to have a generator, especially if this is implanted on a limb. This concludes our presentation. Thank you very much for listening and for being interested in this very important technology to relieve pain in patients with peripheral neuropathy.